oncologist from Bhubaneswar, and he's going to be talking on the topic getting real with Ribociclib. Over to you, sir.
Thank you organizers for giving me the opportunity and thank you Novartis. So we'll discuss getting real with ribociclib. So whether the data is being reflected same in the real world scenario. So randomized controlled trials and the real world scenario, whether the evidence is matching or not. So this is a very important topic. The majority of oncologists, they look at overall survival in metastatic setting. So overall survival is the first treatment goal. Despite time immemorial and despite multiple trials, when we look at the trials, whether they are efficacy part, we look at whether the primary endpoint is OS or not, and whether the OS is evaluated or not. So ribociclib is the only CDK4/6 inhibitor to show statistically significant OS across all the three phase 3 trials. So Monalisa 2, it was in first line, Monalisa 3 included first and second line, and Monalisa 7 was a premenopausal subset of first line. And if we look at the OS data, for all the three, ribociclib had a data for that, which was lacking in palbociclib, and abemaciclib only Monarch 2, the data was there. So how much benefit was there? So median overall survival of 5 years was there when given this first line, and across all the trial, at least minimum of 12 months was there. So that was a good jump from the only the hormone backbone. So addition of ribociclib increases at least 12 months of overall survival. Coming to the real world evidence, there are two studies, one is complement and another is Ribana, and each of them had around 3,000 patients. So close to around 6,000 patients data was there. So study designs covered nearly 6,000 patients from real world practice. The most important thing is that the ECOG PS of 2 was allowed, brain metastasis was there in that, and also visceral metastasis was taken into account in the real world data. So one is the complement and another is Ribana. Coming to the complement study, it was ribociclib plus letrozole, and it was in first line, and treatment was continued until disease progression. The primary endpoint was safety and tolerability, and secondary endpoint were time to progression, overall response rate, clinical benefit rate, and patient-reported outcomes. Coming to the Ribana, it had three arms. So one was ribociclib plus aromatase inhibitor or fulvestrant. Another one was only endocrine monotherapy, and third arm was chemotherapy. So looking at the clinical evidence from the complement 1, that is the largest real-world study across the CDK4/6 inhibitor. So as I told you before, so this was a real-world population which included the CNS metastasis, nearly 51 patients was there, ECOG PH2, 112 patients, and prior chemotherapy, 194, and visceral metastasis was also included. And some patients had all the three. So some patient had CNS metastasis as well as prior chemotherapy. Some patient was ECOG PH2 with visceral metastasis with CNS metastasis. So that was a diverse, large population with subgroup, more representative of the real world practice was there, which was not studied in the randomized clinical trial. So coming to the adverse event, as expected, neutropenia was the most common adverse event, followed by transaminitis and very few QTC prolongation. Coming to treatment discontinuation rate, it was less than 10%. So the more than or equal to grade 3 and leading to treatment discontinuation was very few. Coming to the efficacy, so under an exploratory analysis, median PFS was 26.7 months. So once you start the combination of the hormone agent plus ribociclib, more than 2 years was the median PFS. Coming to the response rates, again, it was a good response rate of nearly 70%. So that included your partial response, complete response, and a stable disease. So clinical benefit rate, high clinical benefit rate was achieved. And CDK4/6 inhibitor and CNS metastasis, that is always an area where all the oncologists look into whether the activity of the CDK4/6 inhibitor was there in the CNS or not. So the data for abemaciclib was there, and this study looked at the data for ribociclib. So complement is a phase 3B real world study, included 51 patients with CNS metastasis, and abemaciclib had 58 patients. And if we look at the what is the efficacy, that was a consistent efficacy across subgroup of clinical interest. And if we look at the CNS metastasis, again it was nearly 27.1 months. So the data for CNS metastasis, which was lacking earlier in the randomized clinical trials, is now there from the real world evidence. Coming to the across other population like prior chemotherapy, ECOG PS2 and visceral metastasis and ECOG PS2, again it was a very nice of 18 months to 19 months. So if we look at visceral metastasis, which is a dreaded complication of cancer, and visceral metastasis and prior chemotherapy, it is 13.7 months, and visceral metastasis and ECOG PS2 it was 18.8 months. So these data were mainly not there in the clinical trials. So coming to the whether the quality was affected or not, the answer was that the quality of the life was well maintained throughout the treatment. This was from the complement. Now coming to the Ribana. So this is an ongoing prospective study. This is looking into 3 arms as I told you earlier, Ribociclib plus a AI or fulvestrant. The second arm was endocrine monotherapy and the third arm was chemotherapy. And it includes ECOG PS both 0 and more than 1, metastasis CNS, liver and lung. So it had, if you look at the distribution of the patients, the Ribociclib arm had 42% which had metastasis in CNS, liver and lung, compared to endocrine which was only 26% and chemotherapy was 67%. So coming to the median PFS, the Ribociclib plus aromatase inhibitor or fulvestrant, it was 31.7 months compared to endocrine therapy of 25.7 months and chemotherapy was a paltry 15.3 months. This establishes the fact that even in presence of visceral metastasis, the drug works good. Coming to the adverse event and safety profile. So the neutropenia was again the most common, 24.2%, followed by nausea, fatigue and leukopenia. And transaminitis is the adverse event of special interest, which was only of 3.7%. So outcome reported in phase 3 trials are achievable in real world practice. So median PFS in the complement and Ribana was 26.7 and 31.7 compared to Molisa 2, 7 and 3, which were something like 25, 27 and 33.6 months. So the randomized clinical trials are being extrapolated into the real world data. So coming to the guidelines for Ribociclib, already it is made through the clinical trials. Already NCCN has given it as a preferred category 1 recommendation, and ESMO also mentions it as a first line treatment. The beauty of the drug is that ESMO MCBS score, that is the magnitude of clinical benefit scale, that is 5 in Molisa 7, which was almost unheard in the other 2 CDK4/6 inhibitors. So Molisa 2, 3 and 7, that has got a score of 4, 4 and 5. So this was not there in the other CDK4/6 inhibitors. The 3 CDK4/6 inhibitors are different, as it was there from the initial days. We know that the off-kinase activity, off-target activity has been very less for the Ribociclib. So the Ribociclib is different from palbociclib and abemaciclib because it has got a better CDK4 activity and the free drug concentration is also very high. So that is the reason that it has got a very good CNS activity. Coming to the summary and conclusion of my presentation, outcome from randomized clinical trials are replicated in real world experience. Guidelines recommend early usage of CDK4/6 inhibitor for patients with hormone receptor positive, HER2 negative advanced breast cancer. And it has got a longest median OS of 63.9 months. And if we look at the real world evidence, again that has been extrapolated into from the clinical trials, the data looks very similar. And the quality of life is very well maintained with the Ribociclib. Thank you.